So you've seen the videos, you're a believer. You bought the book, and now all of a sudden you're going to be smart. No, you're not. You just got the book, and in it is the Rosetta Stone. This is the translation of all of medical minds. We actually have practicing clinicians who have bought the book and written back and said, really enjoyed it, really made my practice feel better, because it's by doctors for doctors. So let's talk about how to use the book. Remember that we start with patient-centered learning. And what does that mean? It means you start with someone presenting to medicine with a problem, the chief complaint. If you haven't subscribed yet, please do. I post a new video every week on how to learn medicine, how to think like a doctor. I'm Dr. Philip Tisdall, practiced pathology in small hospitals for decades, have spent the last 12 years teaching medical students, have formed some opinions, having listened to all the failures and frustrations of you. I've got my own opinions, and I'm promising you they work. Early in my teaching, it became evident to me that even though the system thinks it's teaching you clinical medicine, it's not. And I'll give you a really good example. I happened to be teaching up in Chicago, and I followed the PhD doing endocrinology. And our books were almost identical. And so I thought, well, I'm just not going to repeat my pathophysiology or endocrinology. They did that last week. Instead, what I did was I started with patients presenting with endocrine problems. And I had 3 hours, and I had to stop after 45 minutes. It was so hard for the students to take subject-based pathophysiology and flip it into how to think of it in patient care. Literally, their brains were running out of their ears. We all had to go lie down for 15 minutes, and I had to continue with the classic method because it was that big a mental shift. So if it's that hard, don't think you're going to cram your way into this. It becomes a whole way of ordering your facts. It requires someone to teach you how to do it, and then you have to practice it. But it all starts with, what do I learn? So note that every time I do a system, the book is written in heart and vascular and lung, just like everything else in the world. But the first chapter of every system is clinical pathologic correlation. The clinical is, if I'm in heart, what are my patient's symptoms? Who walks in the door? And the answer is, heart has 5. Are there others? Of course there's others. We're doing the 5 that you keep in your head because it's 90% of your patients. So when I say heart, you're waiting for a patient encounter that is shortness of breath, edema, chest pain, palpitations, syncope. Every system has a finite number of symptoms that are going to get you into the 80-20 break. When I say lung, a nice one. Shortness of breath, cough. That's it. When I get to endocrine, yeah, that's harder because you've got to recognize patterns. So that's a perfectly good one to draw a little figure and put all the little symptoms and signs on it and do that as a flashcard. That's not a bad way to practice because you have to recognize them all together. Neuro, man, neuro is the reason it's at the end of everything is neuro's not like anything else. In neuro, you put together, localize where it is in the system, and then tell me the time frame. And I can pretty much do that. But it's the only one that starts with, I've got a symptom that I then anatomically localize and then put a time frame on it. So you notice every system's kind of different, isn't it? You know what the hardest one is? I'm just doing this at the school I'm teaching at now. Kidney. Man, I've tortured kidney for years. At the end of the day, there are 8 presentations. There's no way to lump it. You can do algorithms, tried it, didn't work. Tables, tried it, tables. You're just left with learning them, right? You got to do failure stage 4, 5. You got to do oliguria, hematuria, edema. Yeah, that's a nephrotic syndrome. Resistant hypertension, stone colic, and flank pain, fever, infection. You just got to start with all those places. And once you've got that, then you've got to say, what other organs do I have to rule in and out? Well, it turns out you kind of got to practice that and be taught it. So why is this idea of chief complaint and its differential so difficult and so foundational? When a patient comes in with a symptom, they often come in with many. And so you've got to have a place to start. And what better place to start than something from which you know it's time-honored because it works. So when I say to you, someone comes in with shortness of breath, the differential is going to be heart, lung. Boy, that just makes everything easy. But now you have to bring in pathophys. What that means is, if it's heart, you've got to have a picture of the pathophys, and then you say, okay, what do I look for in symptoms from that? What do I look for in physical exam from that? And then what testing am I going to build off that? So when I say shortness of breath, part of the differential is heart, and in the heart, it's the family of left ventricular congestive heart failure. Have you got the picture? Can you draw your basic heart? Remember, chronic disease. All these things have to be placed together, don't they? That's why this isn't easy. So here's our chronic disease. Here's our compensation period. Oh, what's that going to be? Yes, it is. It's going to be our homeostasis adaptation. So the first thing in congestive heart failure is, have I got evidence of adaptation? Have I got hypertrophy? Meaning, have I got a big heart? So all of a sudden, we've got a picture when we're saying, here's how I think of my normal thorax, congestive heart failure. First thing you're going to do is take your heart and make it big. Then we're going to tip it into failure. Well, okay, you've done all the physiology arguments. What's failure? Oh, it's the inability to pump in the blood that was delivered to you to pump it out. I don't know how to test for that, but I do know how to test to say, if I can't get it all out, my heart is going to get bigger because I've got more blood, and I'm going to have increased intraventricular pressure. I know how to test that because now I can watch it back up into left ventricle. I can walk it back up through all the pulmonary veins. And when it's greater than 20 millimeters mercury, I've got edema. Okay, so now all of a sudden I see my shortness of breath because there's my compromised alveolar gas exchange. Can you do the physical exam of that? Well, you can, right? Because you're going to have displacement of left ventricle. Got the picture up there? Displacement of left ventricle. That atrium is pumping into a dilated ventricle. There's my S3, S4, my Gallic rhythms. And then when I go listen to the lungs, there's my crackles. Okay, so a stethoscope actually teaches pathophys. Testing teaches pathophys. What about imaging? Well, you're going to see what you're going to see in heart, right? You're going to see a big heart, and you're going to see the pulmonary edema. Yeah. So you can see every time I say chief complaint, and you flip up the pathophys, every one of those has a picture and a story. And then you're going to say rule in, rule out as you go down it. So it turns out you're actually not memorizing differentials. Differentials are a test of whether you understand pathophys or not. And every organ system starts with, what are the symptoms that come from failure in this system? And here we have Appendix A, chief complaints and their differential diagnosis. Now look, skinniest little part of the book, right? And it drives me insane. It's actually the whole book. All the rest of it is just commentary on how you do that differential. Because when you can do this, it's because you know all this. And so when students ask me, how do I know I'm ready for the exam? Oh, for sure, do your practice exams, get your score. That's perfectly fair. But the other thing that I tell them is, when you can go in here and you can pick any of the 50 to 60 chief complaints, and you can walk through the differential explaining why in pathophys, you're ready. That's 70% of your exam. Supposing you've got the book and you want to get started. Pick a system that you are familiar with. That's probably a pretty good place to start. Let's just say, for example, you started in, I'll just pick one that works well. Let's pick lung. Here we have the start of the lung system. It is who walks in the door. And you'll see there's only two: shortness of breath, dyspnea, and cough. Now look how this is going to simplify your life, because it says to you, okay, I've got shortness of breath. What other organ systems are in my differential? And the answer is, it's lung or heart. Now all of a sudden, you've got to start saying, how do I think about lung? And the answer is going to be obstructive, restrictive. So I've got to have in my brain a way of understanding, how do I find out? When I come to heart, it's going to be left ventricular congestive heart failure. Here's the picture, right? Everything we need to do is going to come off that. So you recognize, if I can't do that now, my next visit is going to be congestive heart failure. But in lung, when you come in and you say, what's next? The answer is your stethoscope. So when you go to, how does the stethoscope tell me where I am in lung? Because the lung sounds follows very strictly from where you are in the lung. The tubes that are ventilation give different sounds than the alveolus, which is crackles. Okay, so now all of a sudden you realize I'm not just memorizing my stethoscope, I can see it placed on structure function. And here comes the most valuable thing for students. And that's it. You're not going to get anything else, right? You got the shortness of breath, you got your stethoscope. Now you're going to have to go to testing. And there's only 3. There's imaging, there's pulmonary function testing, and if it's really advanced disease, failure, blood gases, and SaO2s. So most of the time you're saying, is it imaging or is it PFTs? Well, testing teaches pathophys. You've got to have a picture of the pathology and then say, why does testing prove that? And so you can see all of a sudden, if you can do that table, you've recognized I can do shortness of breath. I can do a differential of heart-lung. If it's lung, it's obstructive restrictive. Show me how the stethoscope teaches pathophys. Full stop. Am I going to go to PFTs or imaging next? And if they have a fever, they have an infection, so you're going to do imaging. How easy is that going to make questions? Your questions will start to make sense. So when I say patient-centered learning has a well-defined process, it does. And every system we start with, who walks in the door, how do you form a differential, and how are you going to tell where you are? So a common question we get from students is, I've already learned all of these facts, and I've learned them in the way that my medical specialist wants me to. But the truth of the matter is, most of those specialists, if they're MDs, suffer from the curse of knowledge. And what that says is, I know because I know, which isn't very helpful to a medical student. Well, how did you know? Well, I've seen 300 of them, so that's what they look like. Well, I haven't seen any, so that doesn't help. What do you do? Well, you're not getting rid of any of that. You still got to pass your local exams. You've still got to impress your local person. But trust me, they just don't recognize what they've done. They've seen so many, and they've done it so many times, they just never even knew they did it. So for example, if you come to the jaundice algorithm, and I have you this huge warning, don't miss the first step. The first step is it more than 80% unconjugated bilirubin? Don't miss, that's a doozy. Well, I promise you, your clinician didn't even know she looked at it. She just went right by, saw it was 50-50, didn't even think about it, and went straight to hepatitic cholestatic. Well, that doesn't help you. So what you're going to have to do is keep your local facts, find out what your local person cares about, and then you're going to have to do this to organize it. That's why we're called medical school companion. We're not medical school. We recognize all of you have all these miserable people teaching you their beloved facts that are this dog's breakfast of God help me, and I can't remember any of them from 4 weeks, and it changes with each new person. Got it. It was the same for me. But I promise you, every doctor does this. The differential of shortness of breath is heart-lung. If it's heart, it's from pulmonary edema, that's left ventricular congestive heart failure. Some of my favorite students always are the students from India that want to come and practice in the States. But to do that, they have to pass our exam. So, of course, they come to exam prep people, which I did for a long time. What my favorite conversations are, these are MDs. These are people already in residencies. And they come and they get the congestive heart failure. I mean, they're already graduate students, right? And they come and I say, well, how did it go? And they will say, well, I was on rounds and the professor was asking questions. And out of 10 other interns, I was the only one that knew the answer. So yes, you've got to learn your local facts. And if this person happened to write a paper on the importance of dog hairs in itchy skin, good for that. Learn what they want you to learn. But that doesn't mean you don't understand pathophys is the foundation, chief complaint differential. Come and learn what every doctor has to be able to do. So when are you going to use my beloved Appendix A? The answer is, actually, you've been doing it all along, because every system you come to starts with clinical pathologic correlation. Heart has 5 symptoms. Lung has 2 symptoms. Kidney has 8 you got to be able to do. Endocrine has these patterns you got to recognize. Neuro has give me the localization, give me the time frame. You've been doing them all along in your systems. What Appendix A does is it puts them all in alphabetical order, and it just includes a few things that didn't come out well in the book. So, for example, I've got some lab testing in there that, maybe that doesn't pop out by itself. I don't think, for example, I'd have a particularly good one on syncope. Fever of unknown origin, that's only in the appendix. It doesn't come out naturally with any system. Probably 90% of Appendix A is just says, go see the CPC table. And then there's a handful more that are sort of standalone, unique ones. But you can take that and make it flashcards and do your differential and practice. If I said to you short of breath, what systems are you in? If, all of that stuff, practice until you can see it all. So if you don't have the textbook yet, you're obviously going to need it and you're obviously going to use it, and you're going to be able to start every system with who walks in the door. And by the time you've read all the chapters, you should then be able to understand why that's the differential diagnosis. You can buy the book by clicking the link in the description. I'll see you next time.